So now that we've talked about the pharmacokinetics, the absorption, distribution, metabolism, and excretion or elimination of products, we want to talk about what they actually do to the body. So the site of action is a really important space to think of. When we're talking about medications for mental health, this is the synapse. Most medications that are going to affect behavior will affect synaptic transmission. And this can be done through a number of different ways, including how neurotransmitters are produced, storage and release of those neurotransmitters. They can actually look like neurotransmitters and interact with receptors to block or activate, etc. And they can also affect the life cycle of those neurotransmitters by either inhibiting reuptake or reducing destruction of those neurotransmitters. So there's a lot of different things that can potentially happen to affect synaptic transmission. So when we talk about receptors, we've already kind of to some degree talked about them, but receptors happen in a lot of places, right? So they are located in the plasma membrane of human cells, and they can control movement, activities like that, right? And the proteins in the membrane are called receptors. These interact with our chemical messengers. Now, we call these chemical messengers in this context ligands. And that can include neurotransmitters, which is what we often think about, but it can also include hormones as well as drugs. And when the receptor is bound to by something, right, a ligand, whether it's a neurotransmitter, hormone, drug, then there's a response that happens, right? So there's a change that happens in response to that ligand binding to the receptor. So when we're thinking about the effects that can happen on the receptors, there's a couple pieces to take into consideration, okay? So many would say that the most important and most complex site of action in the nervous system is on receptors. And we have our presynaptic and our postsynaptic receptors. So if we're looking at the picture here, the receptor structure is the lock, okay? And it has a very specific shaped lock hole, a lock that the key can interact with, right? So the key is the ligand, okay? So it's important to remember that the reason that a receptor exists is to interact with a ligand that's created by the body or is endogenous, right? So we have endogenous ligand. Drug molecules will either mimic or inhibit normal body functions by looking kind of like the ligand. Now, factors to take into consideration are the affinity, right? So the affinity is the capacity of a compound to maintain contact with or be bound to the receptor. So the greater affinity, the tighter and happier it is to be bound. We also have to take into consideration the intrinsic activity, which is the capability of that compound to activate the receptor. So you can have something that is very high affinity that does not have activity and is essentially blocking the activity of that product or of that receptor, I apologize. So affinity is how tight it bounds. The activity is what it does. Does it activate or not? So what we can see when it comes to the effects on receptors, we can see agonism, and that can be a full agonist or a partial agonist, antagonism, or inverse agonist, right? Inverse agonism. So those are the effects that we actually see on the receptors themselves when that ligand, that drug, is bound to the receptor, okay? So when we think about natural or endogenous ligands, the effect is elicited and usually involves some sort of conformational change in the receptor, and it activates some sort of downstream intracellular activity, right? The bound receptor itself does not directly express a biological activity, but it initiates events that happen that can affect stuff, right? So a bound receptor can change as well. It can become an ion channel. It can engage in enzymatic activity, break things down. And drugs that are targeted to membrane receptors can also have a variety of effects, right? They can look like and elicit the same response as our endogenous products. Those are agonists. They may inhibit the activity. Those are antagonists, or they can induce an opposite activity, and those are inverse agonists. Okay. So what we can see is when we have agonists and antagonists, we got a nice little picture here, right? So you have your presynaptic neuron. It's got vesicles that have our neurotransmitters. The neurotransmitters, that little shape in the middle there, right? So that interacts with your receptor and it causes that change, right? Whatever change is going to happen based on the specificity of the receptor and the neurotransmitter. A drug can potentially mimic the neurotransmitter, so the little H over here. So you have your little N and then your H. And this one looks enough like the neurotransmitter that it'll bind to that receptor, but it'll also activate it, much the same as if it were just the regular old neurotransmitter, okay? Our antagonist, our blocker, might still bind with the receptor. It looks close enough, but it does not cause an effect to happen. So it's effectively blocking the activity of that receptor. All right. And to say it a little bit differently in words, we're going to kind of repeat this a few times. When a drug binds with a receptor, it's classified by its activity. Agonists bind and produce an effect. It activates the receptor, much like the natural ligand. An antagonist will bind and does not produce an effect. So it does not activate, it basically just blocks the way. So it will block the effects of the natural ligand. So our agonists bind to the receptor, activate it, and produce a desired physiological response. Now, this can be done directly, like what we saw with the key and the slots, but it can also be done indirectly, okay? So it can actually bind to a separate site than what the neurotransmitter would have bound to. So that's an indirect agonist and still produce that activity, okay? We also can take into consideration if something is, I'm too quiet, I don't know, if something is reversible or irreversible and how that bind happens, but it's important mostly just to know what agonists actually do. So a full agonist is having both affinity, right? So it likes to bind, it binds hard, and intrinsic activity. So it produces a maximum response. Okay, it activates the receptor, it produces a maximum physiological response. Okay. Our partial agonists are a little bit more tricky. So partial agonists can have a differing affinity, but oftentimes the same, sometimes more affinity, but it has less activity. So the response is diminished. So there's a less than maximal physiological response that's compared to our natural ligand. So it's almost like a modulator. Okay, it creates a ceiling effect. Okay, so it can look a little bit different depending on what else is going on. If you have a full agonist that's trying to get onto that receptor, it kind of seems antagonistic, right? If you have an antagonist, well, it's actually activating it, so it's more agonistic than our full antagonist. That's why it's a partial agonist, right? So our full agonist is this higher line on the right here, so that guy up there, and our partial agonist is here. So you're still seeing activity, things are happening, but the response is diminished. Our inverse agonist may have more or less or equal affinity, but then a negative intrinsic activity. So, for example, benzodiazepines are drugs that affect the GABA receptors, okay, and can treat seizures. If you give someone flumazenil, which is a blocker of the benzodiazepine receptor, it will have no activity. So it just blocks the ability of a benzodiazepine to attach to that site. But if you have an inverse agonist at the benzodiazepine receptor, you could induce seizures, right? So it's creating an opposite effect of a full agonist. Okay, so if you have an agonist that stops seizures, calms the nervous system down, an inverse agonist would cause seizures and activate the nervous system. Okay. Our antagonists can bind to the receptor and produce no physiological effects. So it'll block or dampen the agonist activity. Okay. Most of the time they can compete for that binding site on the receptor, and it blocks against binding. Okay. The other piece to take into consideration is the way with which these products bind. So we talked about the affinity, so that's kind of how tightly, how much they like it. And then we briefly mentioned reversibility. So something that's reversible means that it's displaceable, right? So if something with a higher affinity comes along, it can kick off that product. If something is irreversible, it's bound and it is stuck there for the life of that thing, right? It's just hanging out. It is not going anywhere, no matter what. Competitive versus non-competitive is a little bit different. So if something's competitive, it's binding to the same site as the agonist. If it's a competitive antagonist, so it binds to where the agonist would be. So say if it's serotonin antagonist and it's competitive. So it looks like serotonin, so it'll bind in the same site where serotonin would have bound, but it doesn't activate. A non-competitive agonist will bind somewhere else to prevent the actions of the agonist. So it doesn't necessarily look exactly like serotonin, but it'll bind somewhere that affects the serotonin receptor or the activity of the serotonin receptor, so it effectively does not work. I hope that makes sense. It can be a little complicated, but those are essentially the basics of interactions with receptors and drugs.